So stage 3 thymoma is typically treated with multimodality therapy, and that includes surgery, systemic treatment, as well as radiation treatment. Systemic therapy or medical therapy such as chemotherapy is typically used prior to surgery, mostly in an attempt to shrink the tumor and help with the resection at the time of surgery. So it is given in the neoadjuvant setting, like 3 or 4 cycles of chemotherapy. That is a common approach in stage 3 thymoma. It is, however, always a conversation between the medical oncologist and the surgeon whether neoadjuvant therapy is necessary, and that is very much driven by the patient's ability to undergo chemotherapy, as well as the surgeon's concern or ability to resect the tumor up front, or whether neoadjuvant therapy is necessary to potentially help with resectability. So radiotherapy is needed in multiple different scenarios. It can be used in place of surgery in the few patients that cannot have surgery, either because they are too old or have other medical comorbidities that make surgery too risky. And in those situations, we give radiation therapy as the definitive or curative treatment, with or without chemotherapy concurrently. More commonly, radiation in stage 3 thymoma is used in the post-operative setting, meaning after surgery, and there it is commonly used if there are positive margins or if the surgery was incomplete. That is where it is standard based on oncologic principles. There's also some data that suggests that radiation can help the outcomes and make up for the incomplete resection. However, there's also data even in the R0 resected thymomas, meaning completely resected thymomas, and the data within thymoma is actually strongest for stage 3 thymomas, that post-operative radiation, even with a complete resection, improves disease-free and overall survival. And so it is always something that should be considered. It is, however, in each patient a discussion of the risks and benefits of adding the post-operative radiation therapy, as we currently have no prospective level 1 evidence. All the evidence that we have is based on retrospective and large databases. And even though it is highly suggestive, it is still always a discussion with a patient and an individual patient and provider discussion that needs to be informed to allow the patient to make a decision on whether or not to undergo post-operative radiation therapy.